Hello, everyone, and welcome to the first session of the Health Center Preparedness and Response Forum. We're just going to give people just a few seconds to join us, and then we'll begin. Okay, great. Well, again, welcome everyone. This is the first session of the Health Center Preparedness and Response Forum. This is a 4-webinar series. So this first session is on extreme weather, and then we'll have 3 other webinars starting in January and then March and May. Next slide, please. Just a few housekeeping items before we jump into today's webinar, which is on extreme weather. All participants are muted upon entry. We encourage all of you to go into the chat, say hello, introduce yourselves, especially where you're participating from, your organization, your name, your state. But we do ask for any questions to be put into the Q&A, and that way we'll be able to easily access those questions and respond to them. And we will be answering questions towards the end of the webinar. So certainly comments, questions, we encourage all of that. Please put that into the Q&A, but definitely use the chat to introduce yourselves and say hello. This webinar is being recorded and the materials will be emailed to all of you within 1 week. And of course, we always appreciate your feedback. So at the end, there'll be a QR code for the evaluation. Please fill it out. And that way we can continue to improve upon the content of this series. Next slide, please. Yes. So this forum is a joint collaboration of the National Training and Technical Assistance Partners that you see on this slide. The National Training and Technical Assistance Partners, or NTAPs, provide free training and technical assistance to health centers and health center lookalikes. And the funding is provided to provide TTA to health centers to increase patient safety and health outcome and ensure that we're effectively serving our patient populations. And so we certainly encourage you to join all of our other training and technical assistance in addition to this forum series that we are presenting today. Next slide, please. And my name is Alexis Guild. I am the Vice President of Strategy and Programs at Farmworker Justice. I am joined today by my colleagues Bob Burns, who's the Director of the National Center for Health and Public Housing, as well as Craig Mendoza, who is the Evidence and Evaluation Coordinator at the National Healthcare for the Homeless Council. And we are the NTAP facilitators for this session. Next slide, please. And so today, our topic is extreme weather. And so we will be joined by Jeff Jones, who will be providing a presentation on the Extreme Emergency Management Assistance Compact Coalition, which is a PCA collaboration. And Jeff will be talking more about that. And then we will have a panel discussion with myself and Joseph Kenkel from the National Healthcare for the Homeless Council. And then we're going to open up that discussion to everyone because we want to hear from you about what you're seeing, especially around extreme weather, heat and cold. We have resources to share, and then we will, of course, close it out. And hopefully you'll join us for the upcoming sessions, the next one being in January. Next slide, please. So it is my pleasure to welcome Jeff Jones. He is the co-chair of the PCA Emergency Management Advisory Coalition, or EMAC. He is also the emergency management specialist at the Michigan Primary Care Association. And Jeff, I certainly encourage you to share more about your background once you begin your presentation. But thank you and welcome, Jeff. Thank you for sharing your insights. And I'm going to turn it over to you.
Thank you, Alexis. Thank you, everybody. And I'm amazed at the turnout. Amazing. So many of you here. Uh, for those of you I don't know, my name is Jeff Jones. I am the Emergency Management Specialist for the Michigan MPCA, and I am the chair of the PCA EMAC, which is the Primary Care Association Emergency Management Advisory Coalition. And what we are is a coalition of all 50 of the emergency management and preparedness folks in the states as well as territories. And our work is as unique and varied as we are. Next slide, please. Next slide. A little bit about the PCA EMAC, just give you a little bit of background on us. Before September 11th, 2001, there was no cohesive vision. There was no role for health centers during a time of crisis. Very few requirements for emergency planning. We really didn't do anything beyond fire code requirements, evacuation policies, and fire drills effectively. National Fire Protection Agency, life safety, had some minimum requirements for emergency preparedness, but it was very much kind of a ad hoc sort of response. The primary care associations offered training and technical assistance on Joint Commission requirements, strategic planning, those sorts of things, expanding service areas, providing training and technical assistance. So while it wasn't on HRSA or CMS's primary requirements, primary care associations began to add a little bit of that in after 9/11. Next slide, please. This chart here is a way to talk about like the timeline in very brief detail. The implementation of the FEP program in 2002, Katrina and Rita in 2003, Hurricanes Gustav and Ike in 2008, all of these increasingly large and increasingly more dramatic emergencies began to occur. They were larger in scale and scope. They were broader in impact, and people were unprepared. And as time went on, we started deciding that we needed to do a little more about this. CMS joined in with some emergency preparedness requirements after Isaac and Sandy, the Ebola outbreak, Zika, all of those things leading up, obviously, to 2019 and a change, a dramatic, thunderous change in the way we viewed emergency preparedness and the way we did our business. Even leading up to 2019, there was a lot of changes in that the 10 years before that, H1N1, with the pod program from FEMA and making sure that our volunteers were up to speed on those sorts of things. And then 2019 destroyed that. We didn't respond to that emergency in the way everybody expected us to respond to the next big emergency. And so we really had to start thinking a little more diversely about how we were operating. Next slide, please. In 2006 and 2007, we were talking about that next pandemic with H1N5, with all of these different things that were going on. The Emergency Preparedness Learning Team, funded through HRSA and facilitated by the integrated work from 2006 to 2009, was really the impetus for a lot of this. Chicanes and the Mass League were the primary leaders for the longest time with this work with the PCA EMAC. And I can't thank Alex and Tina enough for the foundations that they laid for all of this work that we're doing now. It's amazing. I joined when I started working at the Michigan PCA in 2021. And last year I was the co-chair. This year I'm the chair of the PCA EMAC. And basically we are a volunteer organization that strives to have peer-to-peer collaboration amongst each other to better our efforts for all of our PCAs and for all of our health centers. Here in Michigan, we have 47, I believe now, health centers with more than 350 locations across the state. Um, they are incredibly diverse. They are incredibly unique. They all have their own challenges. They all have their own issues. And they all require a very different approach to how they go towards the preparedness cycle. When they look at their mitigation options, when they look at their preparedness and response options, all of those things have to be tailored to that. And that's a little bit of what I do here now. To give you a little bit, as Alexa said, about my background, I spent most of my career working for the Department of Defense as a contractor doing security systems and vulnerability assessment for military bases around the world. When I semi-retired from that, I wanted to do something that was a little bit more, I don't know, karmically upbeat, a little bit more uplifting. So a lot of my skills transferred into emergency management and emergency preparedness. I spent 4 years in New Hampshire as a public health emergency preparedness coordinator for Stratford County. If any of you are familiar with New Hampshire, that is up in the north end of the state. It is ski country. It is rural. It is quiet. And it was a really great place to really kind of lay a foundation for public health work in my life. I spent the pandemic doing a lot of de-escalation and removal of congregate shelters for the state of New Hampshire. We did a lot of work with first responders and setting up COVID evacuation sites for them. We spent a lot of time developing plans and programs for homeless shelters to decongregate and isolate, and making sure that our homeless encampments had hand washing and other services that they need to provide them with what they needed for COVID. And then I ended up here in Michigan, and it's been a broad ranging experience. But one of the things in all the various different places that I've lived, over the course of my time as a defense contractor, I lived in 16 different states. So I've been all over the country, and everywhere I've been, extreme weather has been a constant. Whether it is hurricanes in Florida, or snowstorms and blizzards and ice storms in New Hampshire, or wildfires and smoke and flooding here in Michigan, it's one universal truth. We're always worried about what the next emergency is. And so when we look at it from both the PCA EMAC perspective, as well as like our individual PCAs, thank you. Policy directives appear to support emergency preparedness work where everything is soft language. So when we factor in that soft language as a guide, it doesn't give us a whole lot of direction, but it does give us a lot of wiggle room to do the work that we think we need to do. We want to make sure that our health centers are adequately prepared for all of the different emergencies that might occur. And we want to make sure that they are mitigating the ones that they can, because honestly, the best emergency that we can have is one that never actually happens. So we want to prepare for those. We want to mitigate those things where we can, and we want to reduce the impact where we can. PCAs now play a recognized role in that response in dealing with the HRSA requirements and the CMS requirements for all of our health centers. I know without question that every health center that's on this call right now is completely up to date on all their emergency plans and their communications plans. They're doing all their exercises, and they're doing all of the things that they need to do to meet their requirements, because that's the baseline. That's where we start. And then we work above there. But one of the things I think it's important to make sure we realize is that the majority of those health centers out there do that with someone who is not a full-time person on emergency preparedness. There's not a single health center in the state of Michigan that has a full-time emergency preparedness person. It's a second duty or an additional duty or a third hat or a fifth hat in some of our health centers, instances. And so we have to find a balance with that. There's requirements and there's things that we need them to do, but then we have to be realistic about what they can do and what they can afford to do and what they have time to do. So The PCA EMAX seeks to play a role in that we want to provide a very broad sort of resource library for all of the PCAs that serve as our members and give them a chance to not have to reinvent the wheel every time something comes up. When we talk about the different sorts of emergencies, and Matt, I apologize, there's not too many more slides in this. This is just going to be a little bit more conversational in this extreme weather conversation. So sorry if I'm not giving you a lot to do. Um, when we're talking about the response to emergency weather in our various states, you know, all the different states have different priorities. Our 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 Florida folks, our Texas folks are all dealing with hurricanes half the year. They're dealing with floods, they're dealing with wildfires, they're dealing with those sorts of things. Michigan, we get smoke, we get floods, we get tornadoes now, which was apparently not something that used to happen here, but since I've been here the last 4 years, they've been a fairly regular phenomenon. But prior to that, not so much. So there weren't really plans for tornadoes in the state of Michigan. And so we had to develop tornado drills and tornado plans and make sure that we were prepared for those sorts of things. Whereas Kansas, Nebraska, Iowa had them for decades, for 100 years. They've been planning for those things. They're a common occurrence. So we have to be as varied about those sorts of things as we can and be as open to all the different things. I know that Christina from the Texas PCA is here, and they've been dealing with floods recently. But floods are one small portion of the emergencies that they deal with, depending on what section of the state. Um, we've got some, they may be dealing with floods one day, and they may be dealing with a hurricane the next day. The day after that, they could be dealing with a dust storm or a fire or tornadoes. So we really do try and be as broad as we can and apply our sort of general knowledge and expertise that we can pull from everybody into that. Um, I think a lot of times that people don't necessarily think about just how ubiquitous our health centers are. They're everywhere. We are literally every place in every state and every territory in the United States and abroad. We're all over the place. And so anywhere something happens, there's probably a health center that's impacted. So we have to think about that. How do we deal with a place, one of our health centers, my apologies, one of our health centers that has train tracks behind their facility? And if there's a railroad disaster, how do we deal with it if there's flooding that blocks bridges? How do we deal with it if there is a wildfire that blocks off roads? Every one of those things impacts our health centers differently. So when we talk about, as PCAs, when we talk about extreme weather response, the key to us is resiliency. We have to be resilient and adaptable to all the things that might possibly happen, and realize at the same time that as resilient and as adaptable as we want them to be, there's very little funding for it. So that's our challenge. That really is our challenge. That's where it comes into. And that's where we lean into our NTAP partners for support. We lean into response agencies for support. And I've spent pretty much the last year here in Michigan really trying to engage our health centers in networking with their local partners. I say start 1 mile, in 1 mile radius. Find the partners around you. Find the local hospitals, find the local health departments, find your local kidney dialysis centers, your long-term care facilities, your regional healthcare coalitions, whoever it might be that operates in that very small scale around you, and get to know them and partner with them and be aware of what they can provide and what they can do and how you can help each other, because mutual aid is a lot of times our only defense in these sorts of situations. We have to be prepared to help each other, and that will help us help ourselves. So we spend a lot of time talking about that sort of thing. We talk about the ways that we can engage with local and state agencies. We talk about the ways that we can engage with our fellow partners in the healthcare coalitions. One of the things that I learned working as a public health emergency preparedness coordinator was the value of working with the state emergency operations centers and how valuable that knowledge and those connections can be in an emergency. And I found when I got here to Michigan, and I found from conversations with our other PCAs that very rarely are any of our health centers connected to those emergency operations centers or to those county operations centers or even like the emergency management directors in their towns. So we really do spend a lot of time talking about the value of those networks and those things that we can share out to our health centers and kind of improve the way they do things and how they do them more effectively. Recently, we've been working with some of our relief partners, Direct Relief, IMC, AmeriCares, those sorts of partners, to make sure that they are really well connected with our health centers, to make sure that in an emergency, if they need those sorts of services, they know how to reach them. They know the processes, they know the policies that are involved, and they know how to reach them, and they're connected to them. So we spend a lot of time talking about those sorts of things. I know in a lot of instances when we're talking about extreme weather, we can get into some very detailed response things. And I really wanted to try and avoid that a little bit today because I think the adaptability and resilience aspect is the key for us as PCA EP people. We really need to make sure that we're giving them as many tools, our health centers as many tools as they can for all the different things, and then teaching them how to use them and teach them how to respond to them so that in that emergency, the muscle memory kicks in. They know what to do. They feel confident in what they need to do. Even for those folks who are a third job or a fourth job or a fifth job, in that emergency, they're going to be relied upon, and we want to make sure that they can handle it and they can do it effectively. So we try and be that sort of, next step and carry that sort of technical assistance into those sorts of roles. Um, and really that's the key thing. As we roll on, we talk a little bit about the different things and that we have available as far as resources. We have exercise templates, we have plan templates, those sorts of things. We've worked with several of the partners here on developing resources and tools for our health centers that have been excellent resources. And so that's really that's really the key to it is making sure that we're adaptable and ready for whatever comes up. And yeah, that's really all I have. I hope that was good. I'm available for questions. Oh, sorry, I apologize. I skipped that, Matt. You can skip that. If anybody's really interested in the CMS rule, you can feel free. Um, but
Jeff,
yeah,
you had a lot of kind of great material,
I
within.
did. I did, and it was mostly there for background for folks to read. I don't honestly expect that anybody needs to be, reminded of what the emergency preparedness rule for CMS is, but there is some good background in there talking about those sorts of things. Um, some of those slides were not in the slide deck that I was sent for review. I apologize. I missed out on those. Um, so please take a look at them when you can. You can go ahead on that, Matt.
Do you want to talk just a little bit about a couple of things? But first of all, just PCA EMAC. You talked about the history of it and so on and so forth. But I guess what are the big pushes right now for EMAC? What are you guys really trying to do? What are the priorities? What kind of resources, whether toolkits or training activities, are you engaging in? I know you guys have done a lot of work with HRSA around, FTCA and insurance and flexibility in times of emergencies. So I wonder if you might want to just chime in on any of that.
Of course. Right now, we're working on developing a resource tool for templates and exercises for our members to make sure that they have as broad a variety of options as they can. We have some toolkits for brand new EP folks at our PCAs. So if you come in and you're brand new and you really don't know much about your role, we have a toolkit that's available to say, here's the minimum requirements that you need. Here's the things that you need to do to meet your requirements at the end of this year, and a checklist to do it, and templates on how to proceed. Um, the templates from National Nurse-Led Care Coalition have been an excellent resource for their emergency operations plans and their communications plans. So we throw those in there and make them available to them. We give them like all of the essentials. So absolutely, there is a link to the toolkit. I know we're going to kind of hold questions, but yes, the answer to that is yes, and we can get access to that to y'all to send out. Um, making sure, absolutely, making sure that we're leveraging our resources and leveraging our partners, making sure that we're doing everything that we can to make sure that our health centers are connected to those partners. A lot of times we find that the PCA may know our partners, the PCA may know the NTAPs, they may be directly connected to the NTAPs and other resource opportunities that are available out there, but our health centers aren't. So making those connections right now has been very important. Um, Supporting the onboarding of new emergency staff, supporting network growth and professional development, um, providing opportunities for training and technical assistance with all of the various emergency preparedness people that we have in the PCA EMAC. We have hundreds of years of experience in all sorts of different emergencies and all sorts of different backgrounds. And we want to be able to make sure that that information is available to everybody and that it filters down to our health centers in a way that is useful to them and allows them to really be able to access it meaningfully.
And a couple of folks, in the questions, have asked about promising practices, and I'm just wondering, with kind of you have a unique group, and you have all of the emergency preparedness leads for each of the PCAs around the country. Are you guys in the process of collecting, or do you, on an ongoing basis, collect promising practices relative to emergency preparedness for health centers?
Absolutely, absolutely. We are working on I hesitate to get all a handbook, but a resource opportunity for best practices and things like that. Things that are just what we think of maybe as common knowledge, but is not necessarily all that common. And collating that and getting it available. One of the things that we talk about a lot of times when we're talking about our exercises and our procedures is that if it's not written down, it doesn't exist. And so you can lose all that information with one key person leaving your facility or leaving your group. So we're starting to really make an effort to write down and make sure that that information is carried over and then shared out. So absolutely, yes, we are working on some best practices. We're happy to share that out either through us at the PCA EMAC, or you can reach out to your PCA EP person in your state or your territory, and they can get with us, and we can make sure that that stuff's available. But that is an ongoing thing. In the last 2 years, we've done a lot to make sure that those sorts of things are getting written down. We have a tool that'll be coming out hopefully early next year. I don't have a timeline on that yet. That is an interactive resource for all of our PCAs to use, and really making sure that they're being as connected as they can be to the health centers, and that the communication flows freely. So we know what they need, if we don't know what a health center needs, we may have it and it may just be sitting there collecting dust, and we don't want that. We want to make sure it's as widely available as we can.
And is EMAC, I guess, addressing or trying to address, kind of, I guess, the current resource challenges that folks are facing? Um,
Yeah, Bob, you're pressing my candor button right there. We understand that there is a lack in the current level of guidance sometimes coming from agencies that we might normally expect to be getting solid guidance from. So there are certain ways that your local PCA, that your PCA EMAC, that your local health centers can fill those voids, and we're trying to work on that. It is difficult sometimes because we don't think of ourselves in that role. Um, we just expect that the information comes from noted resources and we kind of extend it out there. But in a lot of instances, in this case, we are the noted resource. We are it. So we are trying to do a better job of making sure that we are really sharing the information that we have, the information that we know, and the things that we're doing. Working on a little library of templates for different types of exercises, both tabletop and functional, for health centers to make available, because no one should have to reinvent those particular wheels. If they need a shelter in place exercise, if they need a power outage exercise, those sorts of things, we want them to be able to have something available that they can pull from, change the names on, change the scenario to fit exactly what they need, and do it instead of having to go, all right, I have to sit down and write this intimidating exercise from scratch.
Mhm.
There's no need for that. There's no need for any of that. So we are doing what we can to try and fill that void in knowledge right now, but it's a challenge. It's a big challenge, and yeah, that's we're doing the best we can with what we've got. But there's more that we can be doing. There's more that
And
we can be doing.
in terms of the federal agencies, HHS, BIPIC, ASPR, FEMA, are there any really strong resources? And by the way, we will have a resources list in the presentation slides for those
Excellent.
looking for it. But in terms of getting good information, from the federal government, is there anything you can point to in particular? And have
Sure.
there been any changes in that guidance over the last few months or the last year or so that you might want to highlight?
I would say that two things. BIPIC has always been an amazing partner for us. They are the answer, the think tank, the knowledge pool for HRSA, and they've always been very responsive. We worked with the folks there quite regularly, and they are a go-to for our health centers and those sorts of things. As far as resources, the ASPR tools that they have available, the resources that they have available, are super deep. um, I find that sometimes I'm a little bit challenged by maybe the age of them. They don't update them as regularly as I would like personally, but there's so many of them, you can pretty much find anything you want from them. As far as challenges, absolutely. As far as challenges, I would say that, yeah, personnel, the speed at which the response that you might be hoping for has changed.
All right. Well, Jeff, thanks very much for all that information. And we're going to kind of move into the panel discussion right now, and we might pull you into that a bit. And then we're going to do a little open Q&A at the end. But right now, we've got Alexis Guild, our one of our hosts, the VP of Strategy and Programs from Farm Worker Justice, and Joey Kenkel from the National Healthcare for the Homeless Coalition. He's their research and data manager. Both have had different and varied experiences around health centers and have some great information and perspectives. And then maybe Jeff will yank you in on a couple of questions as well. So let's start off with the first question, which you can throw it up on the screen if you would like. But I guess, as you mentioned, Jeff, we're in a period right now where extreme weather seems to have become the new normal, and so we have to accommodate that in the health center world. And so I guess the first question, and I'm going to direct this to Joey, it's how are healthcare organizations and communities adapting their services and infrastructure to respond to the increasing frequency and intensity of extreme weather events? So how are people, dealing with, this being a frequent and kind of intense situation? The experiences in Texas recently with floods, which were linked to Hurricane Barry and low pressure areas. And then, of course, Texas also had, some snow and ice a couple of years back, across the board. And then, the northern states are facing, heat and fire and smoke and all that. And Joe, I know your focus is around, folks who are, experiencing homelessness. Um, but would really like to get your thoughts as to how people are addressing these changes. So please go ahead.
Sure. Yeah. Thanks, Bob. Hey, yeah, everyone. As Bob mentioned, I am with the National Healthcare for the Homeless Council. So much of my experience and knowledge is from our conversations with healthcare for the homeless health centers who serve unhoused individuals and folks that are unstably housed. So, from our various conversations and listening sessions that we've had, one really big takeaway that I'd first share is about the nuance that each community and each type in each health center has, and the nuance of each type of extreme weather emergency. So I've heard the saying before that if you've seen one health center, you've seen one health center. And so the same really goes for preparation and response for extreme weather too. Um, that said, I would love to share some, I guess what I'll call like promising practices for healthcare for the homeless programs and others responding to extreme weather. So the first um, would be health centers creating disaster plans to determine how health center services and outreach will change and remain flexible during an emergency situation. So examples of that include, um, on the front end, before an emergency is even taking place in the planning stages, stockpiling supplies that might be necessary and helpful for folks that are unhoused. Um, Looking forward, once an emergency is identified as coming down the pike, pre-filling medications as much as possible and really planning ahead with patients about how they can access medications during an emergency. Um, Extended and flexible clinic hours when possible. We have some great examples of, for example, health centers in Phoenix that during extremely hot times of summer or during heat emergencies, extending or rather remaining flexible and changing the hours of their clinic to be more in the morning before sort of the peak heat hours of the day. So just remaining as flexible as is possible. Also, examples from New Orleans for extending their clinic hours after a storm or hurricane emergency, for example. We've heard of clinics also really emphasizing telehealth and telemedicine during an emergency just to make sure that there is an option and continuity of care for patients during emergencies. While we realize it's not always possible, we do have some promising practices from clinics sharing their ability to repurpose some of their clinic spaces, especially those who have multiple care sites, just as a temporary shelter or as kind of sharing information to the community that their spaces are available to have respite from extreme cold or heat during those types of emergencies. And then the last thing that I'll mention before kicking it over to Alexis is in these conversations, the importance of um, planning and remaining flexible, but also with staff, because we know emergency situations are extremely stressful and really affect the health of patients, but also of staff. So ensuring that the proper supports are set up before an emergency, a weather-related emergency happens, to ensure folks have enough time for breaks and they have the support that they need during those times. So those are
Well,
just some brief takeaways that from our listening sessions that I'd like to kick over to Alexis.
right. Well, Joey, thanks very much. And Alexis, as you go along to, as you come across examples that you want to mention, if you can highlight things that maybe have to do with the patient versus things that have to do with the staff or the facility or funding or, any and all of the above. So please go ahead.
Absolutely. Absolutely, yes. And Joey mentioned a lot of the strategies that he's heard, and I have heard many similar strategies. And what I will say is flexibility is key, always. Flexibility is absolutely key. Being able to adapt to the situation is absolutely key. Another key component, and the next session will really delve into this, but community partnerships. And the next session will really kind of talk more deeply about community partnerships, but they are so vitally important, especially for patients who may be harder to reach, who may not be as familiar with the health center, but may have stronger connections to a community-based organization, certainly in agricultural worker communities. We see that those partnerships with those community-based organizations, and also thinking about employers for many workers, especially outdoor workers, really bear the brunt of these extreme weather events, and oftentimes they are not able to control their environment because it's controlled by the employer. And that sometimes includes housing as well, because there are many workers who live in employer provided housing. So ensuring that health centers are partnering not only with community-based organizations to provide information and provide transportation, provide resources to the patients when there are extreme weather events occurring and in the post-extreme weather event, but also ensuring that employers are getting the information they need so that they can also provide that information to their workers to protect themselves, but then also to ensure that any kind of follow-up, that they are part of that conversation.
And Alexis, in terms of particularly the ag worker folks, um, in terms of the partnership, I guess, with the employer, how big a role is that? And do you have any examples where that has been really successful?
Absolutely. And I'm gonna talk about heat actually specifically
Why
because
don't you, in fact, you know what? The next question really has to do with heat, and I think we're all aware that extreme heat has been on the rise across the board. And we've got folks who are out there, working in the hot sun. We've got folks living in facilities, in public housing and low cost housing across the board that don't have sufficient AC or insulation. And the insulation part can go both ways, whether heat or cold. So Alexis, go ahead, jump in.
absolutely. So agricultural workers, especially, are prone to extreme heat. They are 35 times more likely to die of extreme heat than other occupations. But, we can generalize it to other outdoor workers, construction workers, landscapers, so on and so forth. Um, the employers are really key because not only can they make sure that workers are educated and trained on how to protect themselves from extreme heat, but also they can put those protections in place. And as I mentioned, the workers don't have a lot of control over their working conditions. And so ensuring that the employer provides those protections. And for extreme heat, we all know what the protections are: water, rest, and shade. But if the employer is not, providing that access to water, not ensuring that workers are able to take paid rest breaks, that they have access to shade, easily access to shade, then workers are more at risk of being prone to extreme heat and heat illness and heat injury, and it's highly preventable. So, partnering, again, I'm going back to partnering with organizations, with health centers to provide that training, not just to workers, but also to employers around how workers can protect themselves from extreme heat. Um, and then also ensuring protections. And there are a handful of states who do have regulations around heat for outdoor workers: California, Washington, Oregon, Colorado, Maryland, and Nevada. they all have regulations in place that, and they're varying levels of protection, but they do require that employers provide protections around heat to their workers. And then OSHA is currently reviewing a federal heat standard for indoor and outdoor workers. It was the proposed regulation was released earlier in 2026, and OSHA is currently reviewing that standard. We don't know when that will be finalized, if it will be finalized, but you know, for workers, again, who don't have that control over their working conditions, we need to look at all the different factors in order to ensure that they really are able to protect themselves. And when it comes to housing too, because oftentimes there is no, you know, they don't have the access to the means to cool down in their housing. And I think that's not only agricultural workers, I think it can be applied to, across various populations and various patients who the health centers serve.
Okay. Joey, I know that, you know, especially among folks who are homeless or experiencing homelessness, um, they suffer from exposure to hazards and violence across the board. And a lot of times you have extremely, you know, complex patients. So maybe you could talk about how folks are dealing with that.
Sure, yeah. Um, yeah, as you mentioned, folks that, especially those that are literally homeless, sleeping outside, perhaps in an encampment. So those folks are at really higher risk for things like heat exhaustion, heat stroke, dehydration. So it's really important for clinics to have sort of an educational lens, both for the patients to understand the signs and symptoms of those, which are not always obvious, as well as to community partners. So I'll just build off of Alexis's point about the importance of partners in the community. So for healthcare for the homeless programs, one really important partner, especially in this work, is shelters, both emergency shelters, temporary shelters, to really inform the providers at those shelters to recognize the signs of these types of heat-related illness, and also kind of more in an intentional way, oftentimes even be able to provide some medical outreach at sites like shelters to ensure during those extended heat emergencies, folks have access to healthcare. So one strategy, I guess, that is related to that would be mobile health services or street medicine, which is really critical and growing, especially in regards to extreme weather events and increasing access to care. Um, so folks at health centers who do have street medicine teams can consider doing outreach to temporary shelters, permanent supportive housing programs, et cetera, to ensure that the continuity of care is there, especially for heat-related illness. Um, I will just briefly touch on the importance of outreach with resources, such as cooling gear. One thing that really came up for a lot of health centers in our conversation around heat was obviously the importance of water, of staying hydrated. But for those health centers that are able to support with sharing water in the community, ensuring that folks have access to cold and frozen water oftentimes is like um, a really simple approach to making a big difference is ensuring those water bottles, for example, are frozen. Um, we also have some examples from Phoenix. Again, I mentioned Phoenix earlier of doing some outreach around IV hydration, which is a new area that is really exciting to prevent dehydration during heat events. Um, yeah, community partnerships, I'll just say before we go to the next section, is just that the concept and the theme of community partnerships was just the top item that came up in all of our conversations around extreme weather. It's just, it seems that, like, obviously we talk about how prepared a clinic can be internally, but it's impossible to really be as prepared as you can be without linking with really important community partners and ensuring that everyone is sort of in lockstep as much as possible with both, getting resources out into the community and partnering, co-locating even when possible, to provide life-saving services during these threatening events.
Joey, thanks for that. And you might want to, if you could, maybe follow up with some resources regarding street medicine. I think that people would have interest. I
Oh,
think we're going to
sure.
transition into the next phase, which is kind of open Q&A right now. And I'm actually going to open up with questions around cold weather in general, and I'm going to throw it to Jeff. But if people in the audience have questions that they'd like to pose, please put them in the chat, I guess, or the Q&A feature, whichever is easier, and we'll try to get to them. And meanwhile, I think I'm going to throw this to Jeff since he's had some exposure being in Florida way back and then in New Hampshire and Michigan. Obviously, at that point, people, whether homeless or housed, are all concerned with shelter and warmth and medical care and access and all of the above. And in Michigan, you have a fairly broad state. You have some urban areas, particularly Detroit, where you have a significant amount of public housing and so on, and low-cost housing. And then in the northern part of the state, obviously, much more rural and forested and so on and so forth. So, and I'd like to kind of go back to, there's you're dealing with the cold on one hand, but that also in Michigan, Jeff, you're dealing with some unexpected heat or some atypical heat, at least prior to the last, I guess, 20 years.